All right, good afternoon, everybody. We're going to go ahead and start. Thank you all for coming. I am very pleased to introduce our panel of speakers today that have come here to talk to you guys about primary care. This has been mainly organized by Dr. Karen Blessy. There she is. So she is one of the medical directors at the internal medicine in Ochsner and really feels passionately about the importance of primary care here in Louisiana, and the purpose of this gathering is to educate all of us a little bit more about our options and basically the process of becoming a primary care physician. They are joined by a panel of physicians. That's Dr. Rick Michael next to her. He's a physician in town here in Shreveport, actually. Dr. Susan Kemp, Dr. Carlisle, and then Dr. Lee Engels at the end right there. He is an associate professor of medicine and infectious disease and currently the governor of the Louisiana chapter of the ACP. He is the person who is going to be reviewing all our ACP abstracts, so be nice to him. And I'm, again, very pleased that all of them are here and join me in welcoming them all. I think she has a little PowerPoint for us, Dr. Blessy. I'll give it over to you.
First of all, thank you all for having us. Also want to say hi to Ricky Bass, who may not remember me from back in high school. It's always fun to see a face from the past. Objectives today, this is not your most academic presentation, but we're interested in encouraging the pursuit of outpatient practice for internal medicine trained physicians. And we want to provide an update on the positive changes in outpatient medicine, including lifestyle and salary improvements that have been going on over the past 5 to 10 years in primary care. Physicians have already been introduced, but you can see we have people from the Christus Health System, Dr. Michael's in Concierge Medicine, Dr. Engel is in Academic Medicine, and I'm with Ochsner Outpatient Internal Medicine. There's been a big shift recently. Outpatient internal medicine physicians are in big demand at this point. Louisiana has 126 designated primary care health professional shortage areas, and it's estimated it will require 146 physicians to fill that need. That's not taking into account every other health system that's not in a primary care shortage area that is hiring outpatient medicine physicians. I estimate there are at least twice as many positions available within the state of Louisiana only. So why do we have so few outpatient internists? I think most of you could probably answer that question pretty easily. One is that we have more patients, right? We have an aging population. That being said, a lot of our physicians are aging out, so we have less people trained to do the work for more people who need the care. We also have difficulty training people to like outpatient medicine. Residency clinic is very different from what outpatient primary care is. And hopefully we're going to show you a little bit of that today with our discussions on how our clinics are run and how our days progress. And there's also, in most places, a lack of connection between practicing primary care physicians and residents. So med students and residents don't actually get to see what the real world is like. There's also the perception that hospitalists or subspecialist physicians offer higher salaries and or better lifestyle options. This is not necessarily true anymore. Since I started practicing medicine, I shouldn't date myself too much, but over the last 10 years, the salaries have gone up over $100,000 from my first job offer. So it's a big difference what we're being offered now. So we're going to turn this into a panel discussion. I'm just going to ask each of these physicians to give us a little conversation. Can you turn on the lights so she can see the panel? And then we're just going to sit and go through some things we want you to know about primary care and our trek through medicine to get to where we are now. Not all of these panelists are still doing primary care. Some of them have taken other paths, and we want to talk a little bit about that as well.
So my name is Rick Michael. I grew up in Shreveport, but I didn't do any of my training here. I did medical school in Houston at UT, and then my residency training in internal medicine and pediatrics in Nashville at Vanderbilt, and then moved back here in 2002. And I moved around a lot. Not terribly proud of that, but it's I've been looking for what was best for me in medicine. I've had a lot of wonderful experiences, and I think MedPeds lended itself to working in a lot of different settings. But I've done outpatient traditional practice with a hospital practice too. I've done a little hospital medicine. I've done a little urgent care, and now I'm doing concierge medicine, which I've been doing for almost 2.5 years now. I took over a practice that Dr. Emma McCarty, some of y'all probably remember Dave McCarty. They moved to Boulder, Colorado, but I took over her practice about 2.5 years ago when she moved to Boulder, and I've really enjoyed that practice. So that's what I'm currently doing.
I'm Susan Kemp. I am Baton Rouge born and bred. I moved here in '96 to go to medical school. And so I finished medical school in '99 and then did my medicine residency here, and I finished in 2002. From there, I went over to Marshall, Texas to practice traditional medicine. I had a private practice where I did both outpatient work and then rounded on my own patients there. And about 4 years later, I found my way back home to Louisiana. In 2006, I opened practice here with Christus, a private practice, and I've been with Christus ever since. While I was in Marshall, I was able to go and get some extensive training in wound care as well. So now my day pretty much consists 50% wound care and 50% of traditional primary care. And when I moved back here, I was blessed to have amazing hospitalists, so I do pretty much outpatient internal medicine. So my day is 8 to 5, Monday through Friday, and I don't have after hours rounds or calls or weekend, which has been great because I'm also a single mother. So there's a lot of flexibility built into my world, and I've been very blessed to have the background and training I did starting from this institution, and I've been able to enjoy that every day.
My name is Kelly Carlisle. I graduated from here in 1997 and went to Little Rock to train with MedPeds for 4 years, and then finished and started a solo MedPeds practice in my hometown of Minden, and was there for about 5 years. I was, solo MedPeds, which was very rigorous and very demanding, and I think after about 5 years, I wanted to have a little bit different experience, so I started moonlighting as a hospitalist in Monroe at Glenwood Regional Medical Center, and then liked that enough to close my practice, and I decided to move to Shreveport, and I've been working with Christus since 2007, and currently at Highland as an inpatient hospitalist, and I work for a company that is contracted with Christus called Sound Inpatient Physicians. So I'm now a hospitalist, but do have some insight to offer about private practice and solo practice in particular.
All right. Good afternoon. I hope everybody got a nice more sandwiches probably back there waiting for you, promoting food. I'm Lee Engel. I'm currently Associate Professor of Medicine in New Orleans and the Governor of Louisiana, ACP. But I came to Louisiana on a whim for graduate school to New Orleans, and I got my master's and a PhD from under the gentler Richard O'Callaghan. I know you have Denny O'Callaghan up here, who has tortured many med students and probably some residents in his time. I understand he used to have oral microbiology exams. Yeah, we had Richard O'Callaghan. He didn't do that, but he was pretty tough too. But I wasn't even thinking about med school back then, and then right before I got my PhD, I said, well, test tubes aren't talking to me, and I like to talk a lot. So med school was the next step. So I stayed down in New Orleans, and I went to med school there. Back then, they didn't take anybody from out of state, so I think I was the only Yankee boy, I'm from New Jersey, that was in class. And I used to sit in the third row when I was bald back then, and they would sit in the back, right about in the back, and they would tell me I was blinding with my bald spot. So, yeah, but I love it down in Louisiana. It's been great. And so I did my medical school, then I did internal medicine, and after that I did a fellowship in infectious disease. I stayed in New Orleans. You meet a girl and that's it. You just gotta stay with it. You follow your better half. That's the best thing you can ever do. And infectious disease fellowship. Then Katrina hit. I was also the oldest man in my medical school class. Katrina hit right when I was in infectious disease fellowship. I was going to do 3 years, but they told me the city would close down, so I finished in 2. which is standard for clinical. And then I hooked into a postdoctoral fellowship with physiology and pulmonary critical care I was supposed to be on a 2-year NIH thing. And then the dean asked me if I wanted to be associate program director one day. So I went from a research fellow to associate program director in one day. You never know what a hurricane's going to do for your career. About the same time, one of my mentors asked me to get involved in the ACP, and I became the associate chairman. So the person who runs the stuff for the residents and medical students. I did that for about 8 years. And a couple of years ago, someone called me and said, "Lee, we'd like you to run for governor of the ACP for the state." So I said, "Okay, I've got to learn to say no." I highly recommend everybody in this room learn to say no. Because if you keep saying yes, all you do is get more and more work. But this is good work. So now I'm in charge of the ACP, and I'm going to throw a couple little plugs if I have a second to talk about ACP stuff. I know we have a deadline. If you haven't sent your abstracts, this is directed to residents and med students here, was the end of October. But if you still have a few, please get them to us. We will be happy to take them. The meeting, I had to write this down, I can't remember dates. Our associates meeting is actually going to be in New Orleans this year at University Medical Center. It's on January 23rd. That's a Tuesday. So please get those abstracts in, and my colleague, Dr. Sani, will be reviewing those, and I'll probably be looking at a lot of them as well. The more, the merrier. That's the way I look at it. We actually had our associates meeting here, was it 4 years ago or so? 4 years ago was the first time we ever had it up here, and I would not be adverse to bringing it back up here in the near future. It's a long way for you guys to travel every year. Every now and then, it's nice to see everybody travel up this way, so I think we should do that, plan that again, and we had a great meeting up here. I understand my colleague, Dr. Blondin, fell down and got hurt, so we'll get her patched up by then, hopefully, get her back to work. A couple other things to mention. We would also have our annual Louisiana chapter meeting in Baton Rouge. It's going to be March 23rd. That's a Friday, Saturday, 2nd and 3rd. And that's when we have our Jeopardy competition. And speaking of Jeopardy, what site has won more Jeopardy competitions in the last 20 years than anyone else? Does anybody know? You have, Shreveport. This is the old trophy right here. That's the traveling trophy. I see it. And Miss Peggy, I understand she retired. She had asked me a long time ago when we retired this trophy to retire it here. And seeing how Shreveport has won this trophy 5 times, the next closest is 3, was Baton Rouge and Mississippi, when Mississippi used to join us. I am going to leave this trophy with you. So congratulations on having won this the most amount of times. Now you have to go fight Lafayette now, because Lafayette's won the last couple of years. So I expect you all have a good turnout for that March meeting. But you've really done very well in the Jeopardy competition. Lastly, the National Internal Medicine meeting is going to be 2018 this spring, April 19th to 21st. That's going to be in New Orleans. Any resident who wants to, they have an abstract competition for that, and you should, if you're interested, if you can get some time off to come to the meeting, you can submit the abstract, your abstract. Use the same abstract if you want that you sent to to our regional or state meeting. And the deadline, I think, is November 15th. It costs $75 to submit an abstract, but they will, if you get accepted, they will waive your fee for the meeting, so you get to go to the meeting for free. It's actually a very cool meeting. I've never been to a national ACP meeting. I'm embarrassed to say the first time I ever went to one was when I was elected governor, and now I always go because I get to go. But they're really, really cool meetings. They have all kinds of great events going on and hands-on stuff to do, and so it's really good. Lastly, just as one more plug for ACP Fellowship, I'm sorry, hogging all your time. I'm really striving, our national meetings there, anybody, for my colleagues, faculty, if you've been a member of the ACP for 2 years or more, and you want to become a fellow, I'm really striving to push as many fellows as possible. There's a couple of routes, but the easiest one is just send me your CV, and I'll write you a letter, and we'll get you in, I hope. That's my plan anyway, and I really need to have everything done by December. So deadline's like January. So anybody here who's interested in the ACP Fellowship, please, I might be sending you letters and emails anyway, so that's my next step. But I'm happy to talk. As far as my clinical practice, I basically an academic hospitalist at this point. I did have an HIV clinic I was working on until actually just recently, which was HIV in primary. It was really a primary care clinic. We do a lot of primary care in our HIV clinic. But I found out it was really too hard to be a hospitalist and a primary care physician at the same time, at least in my institution. The amount of that it wasn't really set up to really do stuff, because if you think about primary care, I think about being in a room with the patient, taking care of things, but there's so much more, as you'll hear today, about that working with new medicines and prior approvals and other things, referrals and things like that our system really wasn't set up for. And unfortunately, I just couldn't keep up the pace and do both. But I'll pass it over. I'm sure we have lots to discuss.
So I'll just give you a brief, Karen Blessey, as I mentioned. I went to med school here, finished in 2002, and then did my internal medicine residency at LSU in New Orleans at Charity. I finished right before Katrina. I searched high and low for months and had planned ahead and had my perfect job all ready to go. And then my hospital flooded and had a bunch of dead people in it, and that went away. So when we got back to New Orleans, my entire practice had joined up with Ochsner. Ochsner was the one who didn't flood and also, believe it or not, was unbelievably forward-thinking. They're the hospital that actually owns a flotilla of boats in New Orleans because they're right by the river, and they figured one day we could flood. So they actually have boats in case it floods.
Was that the first Cajun Navy?
Exactly. But that's just an example of their forward-thinking planning. Anyway, they hired all of us and then eventually bought our hospital, which had never reopened it, and moved us back to be part of that community again. So I ended up exactly where I wanted to be, and actually in the same exact office. But the difference was that Ochsner separates hospital medicine from internal medicine, outpatient. And so as much as I loved hospital medicine, I had to give that up. Now, they offered us to be able to do some inpatient medicine if you wanted, but it would be like a block once a quarter. And so basically it was sort of like being a resident again. I wasn't actually following my own patients. I was just walking in blind and taking care of some people. And then that week when I was in the hospital, the patients didn't stop needing me back in clinic. And so, like Lee mentioned, it was a little bit too hard to be able to do both. So I've been outpatient medicine only since my first year, pretty much, with Ochsner. I then had a couple of children and said, oh my God, I can't be wife and mother and the doctor I want to be and work these kind of hours. And so surprisingly, Ochsner has enough women there that it is part of our culture that when you have young children, you should go part-time and work less. And so I went down to 3 days a week after my first one was born. I had my second child. At some point during there, I think I looked particularly frantic, and someone said, do you want to go to 2 days a week? And I was like, no, I'm good. I can make it happen. So I've stayed with them and then gotten more involved. As my children have gotten older, I've gotten more involved in administration. Over the past 5 or 6 years, primary care has really started taking a forefront in all of medicine. It used to be that the specialists were getting all the attention and all the money, and that's where the dollars went, so that's where the systems were focused. But now with the changes in healthcare, primary care is actually becoming the center of our institutions. So we've done a lot of work to try and make our physicians happy and fulfilled and to alleviate some of the problems that occur in outpatient medicine. And I don't want to take up all the time, so we can talk a little bit about it, but you want to describe your typical day? Does everybody know what a concierge practice means? You want to explain what that means first?
Yeah, so concierge practice is kind of an innovative way to do primary care that's come about in the last couple of, 10, 15 years. It's considered what I've heard it called private medicine. You know, there's direct primary care, which is a little bit different than concierge medicine. They both involve you having a smaller practice than a typical traditional outpatient medicine physician would have. Your patients pay you a monthly fee to keep your practice small, and essentially what they're paying for is access to you. So, you know, my old practice, I had 2,200 patients. In my current practice, I have 250 patients. So it's a lot smaller, and you can see the details a little bit better, spend more time with your patients, and when your patients need to be seen and expect to be seen, you need to be available to them. So
you're available 24/7 by call, pager, cell phone?
Yeah, our system is set up. I share a space with another concierge doctor, so when they call after hours, they press 3 to get mine, and every other weekend, my call partner covers for me, and I do the same for him. So 90% of the time you get me, but after hours, the phone rolls over to my phone. So.
And so do you do inpatient medicine as well?
Yeah, so I do both. One good thing about this practice is you get to spend so much time with your patients. You can keep a lot of folks out of the hospital or get them out of the hospital more quickly because you know you can see them and follow up quickly in your office. But I do at Christus Highland, I do inpatient management. And I've never, in 2.5 years of doing this, had more than 3 patients in the hospital at one time. And like right now, I have 1 patient in the hospital. I'll go 2 or 3 weeks without having a patient in the hospital. So more often than not, I don't have patients in the hospital, but I'm available when they get sick.
And how much does your phone ring after hours?
That's a good question. It varies, and most times I go weeks without a call. I had a call this morning at 7:45 from a patient who was leaving town and just had a question about a cold that they had, and that's the first call I've gotten in 2 weeks after hours. And then I'll go through a stretch. I'll have 6 or 8 calls in a week after hours. And I'll be curious as to what's going on. But those times are rare, and most of the times I don't get any calls. The weekends, I probably average 2 or 3 calls a weekend, but weeknights aren't that busy.
And so I know everybody, I hope you don't mind me prying into some of this, but I know that what everybody wants to know is, so how do you make significantly more money doing it this way than you did before?
For me, for my traditional practice, I never was employed. I was private practice with a 5-man group, and we had really high overhead because of our electronic health record. It seemingly we were always updating our server or buying some modules so that we could get closer to paperless, and it was extremely expensive. But I'm making close to twice what I made in my other practice doing this. So it is, financially, it's been good for me.
And the workload is more or less the same?
You know, it's different. I do a lot more during the day, phone calls, people calling with questions, not necessarily generating an office visit, but they just had a question they want to talk to me about. So I probably talk to 15 patients a day, and I see, yesterday was a busy day for me in clinic for whatever reason. On Monday, I saw 11 patients, but most days I see 5 to 7 in person in my office. And then return phone calls in between and follow up with people.
And do you have to do, I know some of the concierge practices in New Orleans, part of the way it is legal to charge extra for services is by doing some souped up physical or do you have something like that where you have to do an annual exam?
I do kind of an executive physical exam once a year but it's just a good solid annual exam. I offer a couple extra things. Really, I spell out in my contract specifically what people's monthly fee is for, and it's really for access for longer office visits. There's a few things I do, like a vascular screening program, kind of like the Lifeline screening, people that come into town and do carotid screening and abdominal aneurysm screening and lower extremity screening for blockages for peripheral arterial disease. I mean, I made a deal with the vascular clinic at Highland, and I pay them to do that for me, so I know who's doing it and who's reading it, so I trust the results, and that's part of their annual fee. So I've tried to work in some services that are more tangible than access, but really at the end of the day, you have to be careful. When I was looking into this, you don't want to be construed to be an insurance company and providing insurance coverage for people, so you have to be. So I still bill insurance for things that are applicable. When folks go into direct primary care, which is a little bit different, those folks have, I think, 600 to 1,000 patients in their clinic, and their monthly fees are smaller. Those folks opt out of insurance, and it's actually, I've looked into it, it's kind of nice. There's a fee schedule, it's a menu, it's what people want in medicine. They want transparency, and you pay a $50 a month fee to be part of a clinic. When you walk in, it's a $10 copay. Your CBC costs $5, your CMP costs $5. They've got a menu of services, and those folks have opted completely out of primary care or out of insurance programs. So they oftentimes negotiate fees with hospitals. So your mammogram costs $100. CT scans are assigned a value, an MRI scan. So those folks really, millennials like it because deductibles have gotten to be so high that many folks never reach their deductibles. So they like to know what a test costs. So direct primary care has become very popular. I think it started, the father of it's in North Carolina, and it's kind of spread out across the country, and it seems to be more popular now than concierge medicine.
I love is I get test results back that day. My cardiologist, I'll get a bill like this, but sometimes I never get the test result back. I have to call Rick, the cardiologist, to give him the test results. And up here, patients have a hard time getting test results. And he'll call me and go over it with me.
That's one of the things for our patients, because I am part of a large health system. All of our stuff is online, and so your results are automatically released in real time. So it is not uncommon that I have patients calling the office during the day to discuss their results before I've even had a chance to look at them, because everybody wants, like you said, access right away to it. And so our system is set up to just release it. Now, there are some blocks on that. You're not going to get HIV results like that. You're not going to get pathology, cancer diagnosis, or things like that through the electronic records. But everything from your CBC to your chest x-ray comes straight through, which is nice. Do you want to talk a little bit about your typical day? And
Sure. So currently, I'm an employed physician. I'm employed with Christus Physician Group. When I first came back to town, I had my own practice and was independent until about 2011, when the EMR really started being pushed because it's very expensive, like Rick said. So I typically, my day is involved with half my week is primary care and the other half is at the wound care clinic. So I would see maybe we book about 8 to 10 patients per each shift, 8 to 10 in the morning, 8 to 10 in the afternoon, and we allow walk-ins to come in because that's easy business, so we don't want to miss. We don't want people going to Velocity Care or going someplace else who don't know them. So it's always easy to get a cold in or somebody who needs to see you. At least we try to make it easy. Because access is one of the biggest issues. Like recently I just moved my clinic from inside the hospital, which, as you know, being inside a hospital, it's hard for patients to get to you, to like right there in the corner by a Subway. So I'm in a strip by a Subway, so you can come get your fasting lab and get your Subway afterwards. So it works out great. But the access is really important, and the visibility, so people know that we're there and they can get in and come and be seen. That's really my primary care day, and then the other 2 days of the week I'll work at the wound care clinic for Christus. And about 10% of my time is administrative. That I'm the medical director at the wound care clinic, and I'll be the chief of staff at Christus next year. So I'll have some administrative work to do as well with the hospital. But I've enjoyed that because I found that, my primary care training here, I was very comfortable walking out into the real world. Even when I did round in the ICU and round in the hospital, I felt very comfortable walking into the ICU and taking care of patients and out in the primary care world. I know when you all sit at morning report and you're like, oh, that local MD did blah, 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 blah. I've tried to make sure I'm not the local MD anymore because once you get away from the education and from the academic world, sometimes you do kind of lose touch. So you have to really re-engage to make sure you're on top of things. And I still use UpToDate on a regular basis, and that's not a problem. But I've enjoyed having that nice balance and not having to drop and run to the hospital in the middle of the day. When I practiced in Marshall, I was on call Q3. I was admitting, drunk some of the night. I was coming in coding patients. I was cardiology. I was in a small town. I was everything. It was a great experience. However, I'm a working mother, and I have to have that work-life balance. And physician wellness is a huge push for this year and on into the future. And I think it's really important that we don't forget that we're humans first. And you've got to be able to be a mother, and you've got to be able to be, a family member. And I can't be a good doctor if I'm too stressed to actually care. So when I came here and I had the opportunity to have hospitalists like Kelly take care of my inpatients, I have a patient in the clinic who needs admission. I call the hospitalist, and they take care of my patient, and they give them back to me. And it's really a nice balance. So I can actually focus on my patients outpatient. I can keep them out of the hospital like Rick tries to as well, and really feel like I'm doing what God put me on this earth to do every day.
can you talk a little bit about, well, one thing I want, ACP is a great way to be involved as a local practicing physician. The meetings have a lot of information that will keep you updated, as well as some on the clinic management side of it. They've been very useful, and I think a lot of people would encourage you to go to that. Can I ask you what's your call like when you're on call as an outpatient doctor for Christus?
Oh, yeah, it's very nice, actually. So I'm not responsible for inpatient work or the floor work or nursing homes or anyone who call me after hours. my own patients, if they have an issue after hours, have an answering service, and then we have a triage nurse who's on call 24/7. So most of the time, there's a protocol they can follow. If they just need a medicine refill or something simple, the triage nurse takes care of that and notifies our office in the morning. If there's an issue that a patient really needs me, they'll get me on the phone, or if an emergency room doctor is calling and I need to, my electronic records, I can just pull them up anywhere I am and say, oh yes, they've always had that EKG, it's not a problem, or click a button and then the EKG goes to the ER. So I'm able to help facilitate that, but that happens maybe once or twice a month. So I can't remember the last time I've been woken up in the middle of the night. It's been years.
And how often are you on call?
I mean, all the time. I mean, actually, I'm in a practice with a family practitioner, someone who finished a residency in family practice last year, and a nurse practitioner. But the triage service takes care of almost everything. So pretty much, unless I'm going to be out of the country where I can't be reached, I mean, I'm always technically called, but I never really get called. So it's been very nice to have that balance.
So for us, because we're so large, we have a team of nurse practitioners that answer all the calls for the New Orleans region, and then Baton Rouge has the same in our different locations. And so again, protocols. But because there's so many of us, I'm on call one night in about every 4 to 6 weeks. And again, it's not inpatient, so I never have to get out of bed. And our patients generally are pretty well trained to handle things during the clinic, because we don't refill narcotics by phone. We don't, call in medicines that were not prescribed, that you needed a refill on. We don't make it easier for you to call at night. And the only time we get actually called is if there's something that is not go to the ER and not on a protocol, and there's a very small window in between.
And that's really important that you're with a group of other people. Like when I came out, I went with a group of physicians who've been out 3 or 4 years ahead of me. They'd already kind of like experienced, they'd been there, done that, know that, no, you can't refill narcotics after hours. I mean, so I actually had that training from the beginning where I was when you become your own attending and you're not a resident anymore, it's nerve-wracking when you make your own decisions and don't have anybody to report to. But if you have a group of partners who are experienced and you have that person to turn to, it makes a huge difference. So you can help develop the protocols or use the ones they already have, and you already have that kind of built-in partnership ready to go. It really makes a big difference.
One of the things that's happened, did you have something to add?
Yeah, I have a quick question. So just because now you're in private practice, and it's a big difference, our residency, my residents and the residency, we're all probably all the same. And even when I was a resident, we struggled to see 6 patients in a half-day clinic because of all the red tape. It's very difficult for the patients and all the other stuff. But how is the flow through now? What's the differences? Because I know as residents, we really don't get a feel for what's out there in the real world. I think we see great pathology. We learn the medicine, but we don't learn the business side of things and how things work what I call the real world out there.
That is huge. I think one of the most shocking deer in headlights moments I had was when I first saw my patient in private practice, and they handed me a super bill and said, okay, what's the level you want to charge this patient? And I had no idea. They were all level 3s until I figured it out, because I didn't have that training going through. In retrospect, I wish, like when you're in medicine clinic and you go to present your patients to your attending, you get great education from the medical aspect of it, but I really wish somebody would have said, okay, now what level are you going to charge that patient for what you just did? Because that's a huge part of my day, and I can be the best doctor in the world, but if I can't translate that into a business, I'm not going to be around much longer. So I had to learn those on my own, and I went to several courses and just kind of got my legs underneath me, but it really makes a difference, and now they change you to RVUs. If you've never heard of an RVU before, it's going to be a big part of your world. I see the world in RVUs now. So, I mean, I can know that 99214 really isn't, I know how much it translates into my work unit every day. So that's something that you really need to get comfortable with at this stage as you're still kind of developing your style and being in a medicine clinic.
Are y'all familiar with an RVU? You know what that means? It's a relative value unit. It's actually assigned, how many RVUs things are worth is assigned by the government. And then if you're an employed physician, your employer will decide how much they're going to pay you per RVU. And so there's some systems that pay strictly on RVUs, some pay on other things like quality metrics or how large your panel of patients are, or whether you're involved in other things as well.
That's true. And the RVU, I mean, that's if you're looking at a contract and trying to negotiate where you're going to go from here, and they're giving you a contract based on RVUs, and you've never experienced that before, you may not understand how to translate that into what your daily life is going to look like. If they're expecting you to do an unreasonable amount of RVUs per day, and you get out and you won't know until you actually get into it unless you talk to somebody who really can explain the system to you. And like you said, I mean, right now I do the work. This is my value unit for what I get. But during the trend over the next 5 years is going to be quality. So it's not that I just did the work, it's that did I get that A1C down? They're going to withhold money from me if I don't get that A1C down to a certain level. And these are all these measures that they're starting to enforce.
So I want to just ask all of you guys, since I'm sure y'all are aware of that too, that we are now changing our payment models in this country to reflect doing a good job. And we all think we're doing a good job, but the truth is when the patients walk out of your room, there are things you can't control. And this payment model is starting to force healthcare and providers to look for other ways to influence patients' behaviors and get these things done. If you're going out into the world, you need to make sure that the place you're going, it has a strategy for helping you meet those metrics, because one physician alone cannot change that. I mean, in your world, maybe because you have so much time with the one person and they're committed by paying a certain amount to come see you. But in the rest of our practices, if it was just me, I can't do it. Can you talk a little bit about what your systems are doing to help you meet those metrics?
Yes. Well, essentially, tobacco status is a vital sign in my practice. I mean, when my MA checks you in, she's going to have a list of things she's going to run down, like when your colonoscopy was, all these things that you decide in the history and physical at the bedside. These things are all inputted into the EMR to start with, and so that's part of the actual intake. You're going to be asked your mammogram. You're going to be asked the last date of your flu shot. You're going to go ahead and get it before I even see you, just because I have to meet those measures, and even if you refuse to get your flu shot, I get to document that as well. So they've put things in place to kind of help at the bedside, in the actual room. But then there's also some systems that they've built behind the scenes where I actually have quality nurses who are employed in the practice who will call the patient and said, hey, I know you didn't get your diabetic eye exam. Did you miss it? Did we need to get it set up for you? Because I'm graded on it. But then the patient ultimately is going to get better care because we caught that retinopathy early. So we have there's going to be a lot more phone work going forward in the future and a lot more of these kind of measures that need to be met. And we're trying to be very careful to make sure that we're actually getting good outcomes for patients and not just becoming better box checkers.
I can speak a little bit to the hospital care of Susan's patients. So my focus for quality is, number one, picking the right next site of care, and that's a big buzzword you'll hear. Do they need to go home? Are they appropriate to go home? Is it safe to go home? Do they need home health? Do they not have a good backup system? Do they need to go to skilled care in the nursing home? And so our big part of our job is picking the right next site of care. By picking the right next site of care, we will hopefully decrease readmissions, because that's another big buzzword when you work in hospital medicine. The hospital will be penalized for readmissions. If you're readmitted, whether it's for the same problem or not, there's a very, very big chance that the hospital will lose any of that income from the subsequent admission. And so we talk about, did they follow up with their primary care physician? Did we make them an appointment to come see them within 7 days? And now primary care physicians are actually incentivized to see patients within 7 days by certain codes that you can use that will pay you a lot more money than a regular office visit. So Medicare and all those industries want us to help patients be a little bit more responsible about their care so that they can continue that follow-up.
Yeah, so the tie-in with that is in our system, the hospitalists are discharging and saying, follow up with your PCP in 7 to 10 days. Well, a lot of them don't do that. So we have a team of nurses called transitional care coordinators who get the list of everybody who is discharged from the hospital, and they take all of Dr. Blessey's patients and they call them, and then they call my office, and if there's nothing on my schedule, they message my MA or my nurse, and they get them in. We also have a team of coders, which is something to pay attention to too. Like you had to train yourself basically on that. In our system, we have a team of coders who go around, we let you practice for a few months, and then they come in and say, okay, let's look at this. And they teach us how to code appropriately, because if you're doing all the work and you're not getting paid for it, it's charity care, but not the right way. Okay.
Transitional care nurse.
Transitional care, yeah, okay. So yeah, those TCC codes are much higher than a regular outpatient visit. And so that you're incentivized to do them, and it's good patient care. Do you guys have any flexible work options? I've seen a lot of millennials who have told me things like, well, I really want to go to work in Africa 6 months out of the year, and I want to come practice 6 months out of the year. And That one we're working on as far as how to fit doctors in on 6 months blocks, but we do have a lot of variations on the way people practice. Do y'all have everybody 8 to 5 Monday through Friday, or do you have various schedules and types of practices?
We do. Well, our clinic, we are going to have it open 8 to 5 Monday through Friday, so we all going to take turns if we're going to, Christmas is coming up. We always make sure the clinic is covered. But as far as flexibility, I mean, I'm paid based on my RVUs. Therefore, if I don't work, I don't get paid. But then I've been around long enough to know how much I need to work because I'm going to take off some time at Christmas. So it's kind of and I think most of us are motivated by that. I mean, I found when I had a salary on my very first job, I wasn't as motivated to do anything extra and just to kind of just get by and just kind of work. But I mean, could you imagine if your paycheck was like, dinged every time that you had a bounce back on the medicine team? You're a lot more motivated whenever there's finances involved with it. So I found I'm more motivated whenever I have like a goal to meet, when I understand how my goals are going to be met, and it's a very clear, transparent formula. So
how does your vacation work? Do you not get?
I get 5 weeks a year. So, but it's up to me when I take it. So, if I take it all in 1 month, I know that my numbers are going to look a little bit bad until I get back up again. But right now, if I'm planning to take off, a couple extra days, I may squeeze in a few more patients, or I may open up like one of my administrative days and put patients there. Because it's just a balance. It's a pretty straightforward math formula.
So you're not salaried. You're eat what you kill, basically. Mm-hmm. And then what about if you had to have your gallbladder taken out and you're out for 6 weeks? What happens, or maternity leave, or that sort of thing?
Yep. And then, but so with that being employed, my employer offers short-term and long-term disability, which actually my salary would obviously cease if I were going to be out for 6 weeks. Well, and then my disability would pick up and cover my salary. So they're able to shift over to that model. So I have a good backup plan, and there's benefits are very important to look at and to understand when you're looking at a contract and how it would work. But more and more working mothers are hitting I think my medical school class is the first time there is 50% women in there, and it's going to continue to be you're going to have to find that work-life balance, because we are going to have children. We are going to get out, and like you said, it's a nice option to be able to go down to part-time if you're going to have a family. So that's really great.
Yeah, and it was very nice. When I originally joined the private practice, there was another woman there. She had 2 children, and every time she had a kid, she would go back to work within 2 weeks, because not only was she not making any money when she wasn't practicing, she also was paying overhead, because you're still paying the receptionist and the light bill and your portion of the EMR and everything else. And so with all of her pregnancy, she did that. As an employed physician, I was like, okay, see you guys later. I'll be back in 3 months. And somebody else who'd done it before covered me, and then I've covered other people when they do that again. A lot of clinics, too, are going to alternate hours. So, for example, one of my partners is a fairly young guy. He didn't have any kids. He really likes to work out. He comes in at 7 a.m., so he's out by 3:30 because he wants to go to the gym. Okay, but a lot of working people like to have a 7:30 appointment in the morning before they go to work. So it's good for them and it's good for us. We have another physician in my group who has, her husband's an orthopedic surgeon, and she has a couple of kids and an elderly mom that lives with her, and so she works 2 days a week, but she didn't want to make the equivalent salary of only 2 days a week, so she works 2 extremely long days. So she goes through lunch, comes in early, stays late. I would jump off a tall building. But she sees everybody in those 2 days. So she's paid for 60% of a practice, but she's only physically on campus 2 days, and then we cover each other's calls on the other days off. Okay, and then yeah.
Just for both of y'all, what are some challenges you see for just general patient care nowadays with regard maybe electronic health records or insurance companies, changes in medications, things like that, private approvals?
You guys want to? I don't want to take all the.
Yeah, there's, like, I guess any part of medicine, there's a lot of challenges. Trying to take care of your patients. A lot of patients complain that you're staring at your computer screen and not listening to them. That's a big issue you try to deal with. Trying to, as these incentive-based programs come into play, you don't want to let the sickest who need us the most fall by the wayside because their A1C is 8.5%, and you're going to get paid less for that person. So, these are things you think about how you can make sure that patients are helped. Certainly the prior authorizations continue to be an issue, and my nurse laughs that she'll spend 45 minutes going through a process to get an MRI approved, and as soon as I get on the phone with the medical director, it's approved. And I really think they know they're challenging you to commit your nurse to 45 minutes of her time to get that MRI done, because as soon as you get on the phone with them, they're going to approve it. And I think many people, and it has changed behavior, because many MRIs I think about, I say, well, does my nurse really have 45 minutes to waste to get an approval?
But I do want to point that out. You guys in residency clinic, you're probably the ones having to do the prior approvals. Is that right? Yeah. So in private practice, any type of, outpatient private practice, inpatient private practice, your time is too valuable for that. You guys need to learn how to do it, but most systems will have a nurse or an MA or someone else who is trained to take that off your plate, because you need to be seeing patients and doctoring, not paperwork. So same with 9DLs. Ochsner actually now has a system where we have like blood pressure checks. We have ambulatory monitors that people have at home, and so there's a team of PharmDs who adjust their blood pressure medicines so they don't have to come in every 6 months for a blood pressure check, because you can see it electronically. They're setting up a system where PharmDs are going to be reviewing our refill requests. So instead of having 20 messages a day about, can I have a refill on my atenolol? I'm like, well, I saw you 3 months ago and everything was fine. Of course you can. I don't have to think about that. They're going to say, oh, no, you haven't been in a year, come back in. So there's a lot of things going on to take all of that work that feels miserable in a residency clinic off of you. In a real outpatient practice, everybody's working to the top of their license so that you can spend your time on the more challenging, physician-focused dilemmas, not the who's doing the answering the MRI.
And that's
call.
kind of what I wanted to bring that up, because there's a difference between what you see in your residency clinic versus in private world. And a lot of these challenges are actually the same challenges that we as internists in Louisiana have, that somebody in New York has, it's universal. Challenges with the electronic health records, where we're looking at a computer screen now instead of looking at our patients, or we're dealing with prior approvals or preferred medicines. Insurance companies have preferred medicines. All of a sudden they change it. We've got to change all our medicines up for patients based on that. So there's a lot of things that you're going to find generalized that everybody's dealing with, and as a group, as internists, we're working to hopefully change. And we need to, as physicians, we need to be involved in that change, and that's important for advocating for ourselves. Otherwise, somebody in business is going to do it for us, and they're already doing that for us, as I'm sure you're witnessing.
Well, and if any of you guys are particularly techy, I mean, the electronic medical records can do a lot of things that take the workload off the physicians. We've been doing all sorts of things that are making life easier for the physician. Are y'all using your EMRs in that way at all?
I just want to talk too that going back a little bit to what you talked about everyone helping you so that you can focus on the doctoring. If you're going to be in a small town and you're going to be in solo practice, it's not quite as comprehensive as that. You may end up having to do some things that someone else would normally be doing for you, because you just have a very small staff. In general, solo practice definitely is a much harder road to go, because you don't have that backup and that support. But as far as the electronic medical record, my experience was and I started out with an electronic medical record when I very first started practice, a web-based one, before they changed so that HIPAA compliance, where you could leave it up all day, then you could save it at the end of the day, and so I had to get rid of it. But my experience was I had to see so many patients during the day to make my overhead and pay my payroll taxes that I would get behind. I would leave off, I'll finish that chart next, Well, then I was doing charts at the end of the day while I was in my pajamas, finishing up 30 charts, for the day. So it's easy to get behind in solo practice too. But I think if you're in a comprehensive program, a big program like Ochsner or the other places, the electronic medical record absolutely saves you. But if you're having to pay for something by yourself, be prepared that there may be times where you're finishing up charts or on your off hours. It may not be quite as helpful.
Well, and I'm not sure if this is happening up here yet, but at least down in the southern part of the state, groups like Ochsner, as we're growing, we have a clinic in Raceland. We have a clinic in Homa. And it's 2 or 3 guys, out on the bayou, but they have the power of our system behind them. So they have an LPN clinical care coordinator. They may have social workers that are calling rather than physically on site because their group isn't big enough to support one, but you have the rest of the system working for you. I mean, one of the little things that really makes a big difference is our EMR is set up to tell me what's on formulary. I mean, I don't know if you guys have that, but if I try to prescribe, atenolol and their insurance wanted metoprolol, it's going to ding me and say, hey, do you want to try this instead? Well, that saves me the phone call later on in the day when the patient goes home and does it. The other thing is things like injections. Okay, I don't know if you guys are, our record is set up to flag, here's what this patient needed this, and the clinical care coordinators will already input it. So for some reason, somebody on a committee decided that the Tdap should be done. I'm not saying it shouldn't be done, but a lot of insurances don't pay for it. And so if I prescribe it in the clinic, they're going to get a bill, which is outrageous compared to what it would have been if they'd gone to their pharmacy. Well, now they have it set up because we had so many complaints. It dings. If I try to order it in clinic, the machine will say, would you prefer to send this down to the pharmacy because this patient's insurance covers it in the pharmacy, not in the clinic? I'm like, yes, thank you so much, little machine. So things like that, where I would have been fielding this irate patient's call who was charged $200 for a Tdap, there are a lot of things that they can do, and I think that the physicians need to be in charge of leading that. We have a medical director who is a primary care physician who does this at Ochsner, and so every time he does an upgrade, it's particularly annoying because you got to learn something new, but at the same time, there are all these things that are helping us decrease the workload as we go through.
And I do think it's all about compromise, too. There are people who are still solo practice that like not being beholden to anyone. They don't like anyone telling them how many people they need to see. They want to be in charge of their own productivity. And then you have people who, like me, I ultimately preferred being employed, getting a paycheck at the end of the day, them taking my taxes out so I didn't have to save my taxes. You have to pay 15% more self-employment tax when you're not employed. So there's all these little things that at the end of the day, it ends up being, is it worth the headache? So you have to judge that, and I would say after all of it, I'm happy to be employed.
I think you'll find that most physicians, internists now are probably employed. That's the way the trends are. Now I'm going to put a plug in for the other side, the academic side, which most of my colleagues in this room are. I can never retire because I work for the state, and we don't make the same amount that you do in private practice, and that's okay. I got a roof over my head and food in the refrigerator. I'm happy. And my day is insane, and I complain about the insanity, but I love it too at the same time. I never know what I'm going to be doing. I kind of know what I'm going to do every day, but it's very variable. I'll be seeing patients part of the day, maybe in a conference, maybe I drive to Shreveport to talk to groups or something like that. You never know what's going to happen. Some days I'll be interviewing new residents, med students, or teaching medical students, and I love all that stuff. I love the teaching. So if you're interested in, if you have that love for teaching and education, that's great. Unfortunately, that word RVU has crept into the academic world. That's something I never heard of until about 4 or 5 years ago, and I am terrible at business. I didn't learn any of this stuff in medical school and residency, and I'm still learning it, unfortunately. But it does creep up, and people do look at RVUs a little bit, but at the same time, I hear about all this stuff and all this stuff swirling around. I don't really worry about it. At the end of the day, all I'm worrying about is taking care of my patient and hopefully teaching someone, hopefully grooming that person to replace me is really what my dean always says is we're supposed to be teaching those people that will replace us in academia. But most of my residents down in New Orleans, most of them do be going to private practice. There'll be a few stay in academics, but that's one beautiful thing about internal medicine. There's so many ways that you can go with this. You can create your own career and make what you want out of it. So there's a lot of good things to do, but just a plug for academia. But private practice is great too. In private physicians, if you are interested in teaching, also have the opportunity to teach. And I know residents and students come through clinics and things as well. So there's lots of opportunities and differences.
Well, and if we're doing plugs, I will give a quick plug for working for Ochsner. We are hiring. We've been expanding over the last few years. So we have clinics in all of South Louisiana. We actually have something in Mississippi now as well. So if anybody is interested, we do sign-on bonuses. With some locations, we'll also do stipends during residency. And we're paying as much as hospital programs or hospitalist programs. So our starting offer, it's very transparent across the board, but they start off right out of residency, 200. Sign-on bonuses between 15 and 40,000, depending on the location. Our average physician's probably making about 250,000. We have some guys who are working really, really hard, making 300, 340, just as Monday through Friday, outpatient medicine, no call, no weekends. So consider it. If you have any interest, let me know, and we'll try to get you in touch with the people in whatever area you're interested in.
Are y'all putting anybody on clinical trials? So how do you find out about them? Do you have much of a relationship with academic docs who are promoting it?
Well, out in primary care, in my private practice, actually, I do research. I participate in the phase 2 through 4 trials. They're not my own trials; they're the ones that are sponsored by the companies themselves. So I actually have a nurse in the whole department that does that with me, and I found it really has kept me in touch. You know, when Prolia was first coming out, I was part of that trial here, and all the new insulins and GLPs, all these new things that were coming out down the pipeline, I was able to do that. But if I wasn't in that realm, then I think other than patients coming and asking about it, I don't know how patients find out about trials out in the real world.
So we have a research department that does a lot of clinical trials, and usually they will go through the EPIC system and pull for people, and then they ask us, is it okay if we contact your patients about this, and this trial? We've occasionally had things that come through our office. They pick our site. I work in the Baptist, which is one of the, we have about 8 docs in our clinic. They've come through with iPads where they're doing surveys of the patients while they're waiting for us in the room. They've done a weight loss study where actually I think we were just the control arm of the weight loss study. Or the Propel study. Oh my gosh. People love it because they get paid $75, but then we're the control arm, so they don't actually have to do anything other than $400. Oh, $75 a check-in, right? Yeah, I have a lot of my patients on that. So we're involved in several things.
Hopefully most of them, we need physicians in Louisiana, so hopefully most of the residents here will stay here with us, some manner in academia or private practice. That's the goal. Our patients, people in Louisiana, our family, our friends, our colleagues, need doctors. We don't have enough, as you saw early on. So there's a big push, and you are needed and wanted and desired. So and well trained, I know that. So hopefully everybody will stay.
Yeah.
Yeah. So we do have urgent care clinics that are built with us, and so we have some of the locations will have a Saturday clinic. So it'll be, let's say if it was all the 5 of us in practice together, I might take the Saturday clinic. But for most of them, we have urgent care centers that are open to care for the patients.
Who staffs the urgent care?
So we have board certified physicians that work in that department, and they cover. We actually just joined with a group called MHN Urgent Care, which has sites all over Louisiana, in the south of Louisiana, and so we took them over. Unfortunately, many of their physicians were not board certified, so we had to cut back the number of locations we had, and a lot of their physicians are actually going back and doing family medicine residencies or some other type of training to get board certified so they can go back and work. And on the call, when I say no call, I mean the call that has the nurse practitioners who answer the call, and then we get the call afterwards. But no inpatient call.
So going back to the "we need you" conversation, we do, and you are very well trained. You will realize when you get out into the real world, this facility, the LSU, the training you get here is amazing. I had several people who came through my practice in the very beginning, and they couldn't even do a pap smear. I mean, they couldn't even do, the basic things that we do every day that you learn in training. So you have an excellent training here, and you need to be able to leverage that to the best of your ability, and don't be afraid to. So look, are there people in the room with you today? Are the people you're going to be in practice with, 10, 15 years down the road, even in this community? In fact, I was going to go back to Baton Rouge and practice, but I fell in love with the medical community in this area, and to the point where I have a group of physicians, doesn't matter what hospital system they're with, but we're all physicians, and I can still pick up the phone today and call any one of them. So you can, even if you're, like now, if you're looking to get out into looking at a contract, if you're third year and you're ready to go out into the real world, take my cell phone number, take my card, my email address, and if you need something translated for you, I'm happy to, because, it's not about whether you come to my system or your system or anything like that. It's that, I want you to understand, and I'm training you to take care of me in the nursing home later on. I want you to be comfortable and happy and be a, good, solid physician. So that we're very blessed in this area. I feel that our community of physicians is actually really a community, and don't forget that.
Any other questions?
Thank you for having us.
Thank you so much.